My name is Dr. Verma. I'm one of the spine surgeons at the University of Washington. I have a special interest in adolescent scoliosis and adult spinal deformity, and I wanted to present on these two topics. So let's get started. First, I want to talk about adolescent scoliosis. This is one of the most common types of scoliosis that we see, especially in the younger population. It's a three-dimensional deformity. It's both coronal, which means on the front view you see the deformity, but it's also a sagittal deformity, which means when the patient's standing sideways and you get an x-ray, you see deformity. And typically the deformity causes a flatness of the thoracic spine, a rotational deformity, and often there's a very prominent rib hump on the side. So when you typically ask a patient to bend forward, a typical Adams forward bend test, what it does is it puts the ligaments and the posterior structures on tension, and you see the prominence of the rib hump off to the side. And that's often how scoliosis is diagnosed. We tend to operate on adolescent scoliosis when we cross around the 50-degree threshold. Studies have sort of shown that after 50 degrees, these curves start to become unstable and they tend to progress throughout life. And our goal is to halt progression. And then the secondary goal of operating on adolescent is that the curve is very flexible, and you can often correct it almost completely and essentially get it perfect. And I think the third goal of operating on adolescent scoliosis is to prevent breakdown of levels adjacent to where you're operating. So if somebody has a very large thoracic curve, but the lumbar curve hasn't been affected that much, you often can do a selective thoracic fusion and prevent breakdown of those lumbar levels, theoretically, although this has never been proven. And this is an example of what you might see when you have somebody bend forward. This is an example of the Adams forward bend test, how we diagnose scoliosis. But often very mild forms of scoliosis, it's very hard to see, even on an Adams forward bend test. Some terminology as to how we define different vertebral bodies in our scoliosis. We have the apical vertebra, which is the vertebral body that's at the apex of the curve. And then you have the upper and the lower end vertebra. These are the top and bottom vertebra that are involved in the scoliosis. We also have a major curve, which is the bigger curve, and then a minor curve, which is the smaller curve. And often you'll have an inflection point or an inflection vertebra, where this is the level where it seems to change from one curve to another. Very often in scoliosis, it won't just be one curve. It'll be one curve, but then in order to get your head over your pelvis, there'll be a compensatory curve. And the whole science of adolescent scoliosis is really trying to figure out which curves are structural, which means that they are curves that are needed to be treated in a fusion, and which curves are compensatory and are flexible and don't need to be fused. And I'll go over some of that science in this talk. One of the major classification systems for adolescent scoliosis that had a pretty powerful impact in terms of research, but also in terms of decision making, is this Lenke classification system. Dr. Lenke is an adult spinal deformity surgeon, but he had a particular interest in pediatric spinal deformity and really looked at the way we were classifying adolescent scoliosis and broke them out into 6 curve types. The most common is a Lenke 1, which is a proximal thoracic curve. This is what very often you'll see in clinic. And this is a type of curve that is very well treated with a selective thoracic fusion. But often you'll have double thoracic curves, double major curves, where you have curves that extend into the thoracolumbar region. You can have triple curves, where you have curves in the upper thoracic, and thoracolumbar region. In some situations, you'll only have a thoracolumbar curve, and in very rare situations, you can only have a lumbar curve. Identifying the appropriate curve and understanding when it reaches that operative threshold and understanding which levels to fuse and not fuse is an evolving science, and over the last 10 or 15 years, it's really changed quite a bit. And a lot of this is driven by some of the research in the adult side, and one of the fascinating things about spine is how much it has changed, especially spinal deformity over the last 15 years. So if you'll humor me for a little while, I will show you why spine can be so exciting and why some of these cutting-edge techniques for spinal deformity really can help our patients. Here's a case example. This is the patient that has a scoliosis, and if you notice on the right side of the screen, the shoulder is lower than on the left side of the screen. This tells us that when we correct our scoliosis, we are going to drive our left shoulder higher. And on the right side, we see a little R that marks the right side shoulder. And we see that the curve is a right apex curve. So we know that when we push that curve over, that it drives the left shoulder up. So if the left shoulder is higher preoperatively, we tend to do a longer fusion, up to T2. And the reason we do that is so that we can compress on the left side and bring the left shoulder down. Now in the bottom two slides, you'll see the shoulders seem about level. Maybe the right shoulder is a little bit higher. In this situation, we can stop our fusion at T4 because we know when we push over the right curve, we're going to tend to level out the shoulders. And in adolescent scoliosis, there is a cosmetic issue that goes with this. Often there's a shoulder imbalance, there's a trunk asymmetry, there's a prominent rib hump, and doing surgery to address all of these components is I think really important, especially for an adolescent population. The other important thing is decreasing the rib hump. Often people don't just notice the curve of the scoliosis. What they notice is the abnormal shoulder height, the abnormal trunk imbalance, and they notice a very prominent rib hump. And so techniques that are sort of new and evolving to help derotate the spine and help correct shoulder balance using a pedicle screw construct are really kind of exciting. This is an example of a patient that had a very large Lenke 1 curve or a proximal thoracic or a thoracic curve, and you can tell that if we were to correct this scoliosis and push that curve over from the right, it would tend to drive the left shoulder up. And we can see the left shoulder on the left is already elevated, and there's a very large curve. So this is the patient you have to counsel them and say, there's almost nothing I can do to control your shoulders in this situation and make them perfectly level. That in order to correct this scoliosis and achieve a good cosmetic result, we'll still have to drive up the left shoulder. And you see this surgeon went up to the T2 level and compressed on the left side, but despite the best efforts, the left shoulder is still elevated. And often that'll settle down over time, but it's something patients should know preoperatively. Another important thing, I would say even probably more important than the shoulder balance, is looking at the distal level. In scoliosis, it's really important, especially adolescent scoliosis, to know which levels to stop at. You don't want to stop your construct too long, and you don't want to stop your construct too short. One of the ways we figure this out is we draw a line from this, what we call the center sacral vertical line, the CSVL, which is a straight line drawn from the center of the sacrum straight up. And generally the last touched vertebra is the safest vertebra to fuse to distally. So if you look at the figure on the left, there's probably a pixel or two that touches the L2 vertebral body. And so stopping at L1 might be a little bit dangerous, where if we were to fuse this spine and bring it over, there is a chance that if you stopped your fusion at L1, below L1 an additional scoliosis would form. And that's what adding on is. And so in this situation, the right level to stop at would be L2, and if you were really unsure, maybe L3, but certainly not lower than that. Another way that we decide which is the best level to stop at is we look at the disc spaces. Often we'll look at a bending film where the patient will bend from one side to the other, and we look at the disc space that is mobile. If the disc space is able to change directions on the bending film, be off to the left on one film and off to the right on the other film, that tells the surgeon that's a mobile disc space, and that's a level that's safe to stop at. And so in this situation, you see in the middle slide, you see that the L2 vertebral body has a mobile disc space beneath it. And that's why I think that surgeon decided to stop at L2. Another thing that we look at, and this is kind of more cutting edge research, is looking at Lenke 1A curves. And what that means is a type 1 curve, a Lenke 1 curve, a thoracic curve, but we look specifically at the L4 vertebral body, and we're looking to see what the tilt is of the L4 vertebral body. If the patient is immature or relatively young and the L4 vertebral body is tilted to the right, that patient has a 30% chance of adding on or having an additional scoliosis form beneath their fusion. And this is really something that's just come out in the last 10 years. And in these situations, we tend to fuse a little bit longer. And research has sort of shown that fusing longer, one additional level, prevents this adding on phenomenon. That's an important thing that we look at intraoperatively to decide fusion levels. This is the Lenke 5 curvature, or a thoracolumbar curve. In this, often the controversy is whether to stop at L3 or L4. And I personally am a person that really believes in going to L3 and saving on fusion levels. I feel this way because I also treat adults, and I know that the fate of unfused levels next to a fusion construct is not good. And over the course of a patient's life, the level next to a fusion tends to break down. And I think fusing to L4 sort of guarantees the L4-5 level breaks down, and then over time the L5-S1 level breaks down. But if you stop at L3, then you really preserve 3 mobile disc spaces below your fusion construct, and that is a situation where probably a patient could go most of their life without an extension of the fusion to the pelvis. So if you see on the left, the patient has a scoliosis of the thoracolumbar region, and stopping at L3 gives better mobility but slightly less correction. And stopping at L4 will often give you a little bit better correction, maybe you're more likely to get a neutral vertebral body distal to your construct, but then you may be more likely to have adjacent segment breakdown. And the whole decision making on whether you can stop at L3 or L4 on specifically this type of curve is an area of pretty active research. If there's L3 translation that is less than 3.5 centimeters, we tend to fuse to L3 and save those extra levels. If the L3 is translated off to the side more than 3.5 centimeters, then I think it is best to stop at L4. But this is an area that almost at every spine deformity conference we go to is actively debated, and for good reason, because the long-term implications are significant. If you look at spine deformity as a specialty, it's really exciting. Even in the last 30 or 40 years, it's completely changed. We used to initially treat patients that had scoliosis in casts and immobilize them for months. A big change was the advent of Harrington rods, which was a distraction device that would be put into the spine and would correct the scoliosis. This was a huge innovation at the time. What was interesting is that it corrected the scoliosis, but only in the front view or the coronal view. What it tended to do in the sagittal profile was flatten out people's backs. When you do this in adolescents, often adolescents are able to compensate for a sagittal deformity. But when we see these patients in adulthood, they often have problems, and we often are forced to do revisions to help correct their sagittal imbalance, which I'll talk about a little bit later in this talk. Another technique that was sort of developed, this was developed in Mexico by a surgeon named Luque, and he figured out that if we were to use not just the techniques of Harrington rods, but also use segmental fixation, where every vertebral body is connected to the rod, that he had a lot more power with his construct. He was really able to move the spine wherever he wanted, and he was able to correct the spine in both the coronal and the sagittal planes, which means he was able to straighten out the spine in the front view and the side view. And the really important thing about this technique is that it was developed primarily in Mexico, and these are sublaminar wires that are passed under the vertebral bodies. They have a lot of strength and power, and they're very inexpensive. So often in situations abroad, we'll use sublaminar wires, or if we're in situations where we're taking care of a patient that doesn't have a need to have perfect correction, such as a cerebral palsy population, we'll often use sublaminar wires. The controversy with sublaminar wires is they don't have the ability to derotate the spine, and they are often seen as maybe even a little bit more dangerous than putting in pedicle screws. And so they've over the years fallen out of favor, but it's still a great salvage technique. These days, pedicle screws have really become the standard of care. The way these are put in is through anatomic landmarks or sometimes with the use of a C-arm. But the screw is put in from the back into the front, and the screw goes into this region of the bone called the pedicle. And the pedicle is almost designed like a channel that would be perfect to put a screw in. It's almost as if God intended for a screw to be put into the vertebral body, and that's where the screw goes. It's generally put in through a freehand technique, and the power of the pedicle screw is really that it's placed from the posterior aspect of the spine to the anterior column. So you have 3-column fixation of the spine, which gives it a lot of power. This means you can put the spine in many situations wherever you want the spine to go, especially in a younger patient. And you also have the ability to derotate and correct the deformity a lot more powerfully. Advocates such as me for pedicle screw constructs also say that you're able to save the amount of levels you fuse because you're able to pull the spine over to where you need it. I think this is a little bit of a generational thing. Some people think pedicle screws are technically more challenging, where I might argue that Lukey wires and passing sublaminar wires are perhaps more technically challenging and more risky neurologically. This is the freehand technique for pedicle screws, and this has really been innovated in the last 15 years. Again, Dr. Lenke, who is an adult spinal deformity surgeon but really pioneered a lot of this work, did an anatomic study to look at the different start points for pedicle screws. He found that at different levels, the pedicle screw starts at a slightly different place. And this was mapped out and put into a very informative paper. And on this picture, you see that we use a curved gear shift. The curved gear shift goes in along the medial wall of the pedicle, right next to the spinal cord. And if you see this for the first time, it seems to be a dangerous technique because you're putting a semi-sharp probe right next to the spinal cord. But it is actually very safe because you're using a blunt-tipped probe and you're using gentle manual technique in order to get into the pedicle. And once you're past the area where you're potentially dangerous to the spinal cord, you're able to turn your gear shift. As you see on the picture on the bottom right, you curve your gear shift to angle medial, and that helps create a channel where you can place a screw safely. We also can use C-arm to confirm that the screw is in a safe position, and we also use a special ballpoint feeler to confirm that our screw is in the appropriate position in the vertebral body. This technique was studied pretty extensively with fellows and attending physicians, and was found to be accurate to about 93-94%, with very few screws causing a medial violation. And there were very few screws that had a lateral violation. And overall, there was no screw that caused any neurologic or vascular complications. And probably the reason is because even if there's a very small violation of the pedicle with the screw, it's very unlikely to cause a major neurologic injury. And so I think this has really grown to become the standard of care. Although initially, even in the spine community, this was pretty controversial. So when we look at deformity correction, we're really looking at the coronal plane, which is the front view, and we're also looking at the sagittal plane, which is the side view. When we look at the coronal plane, we're often doing a lot of compression and distraction, or derotation. When we're looking at the sagittal plane, we're often putting the concavity of the rod, or we're curving the rod, laying it down, and then we're rotating the rod in order to create a nice kyphosis, or a curve in the sagittal plane. This is a little bit of what rod derotation looks like. On the picture on the left, a rod is placed into the spine, and then we use these large rod benders to bend the rod where we want it, and that in turn bends the spine where we want it. We can also do something where we grab the rod and we rotate the rod, and as we rotate the rod 90 degrees, we take it from a coronal plane to a sagittal plane, and in the same manner we move the spine over, so we're taking a coronal deformity and turning it into a sagittal contour or a restoration of kyphosis. And here you can see that coronal deformity on the left is rotated and turned into a sagittal kyphosis on the right. Here it is again. You see here that the rod is placed in on the concavity of the curve, and then we grab the rod and the rod is placed loosely in the spine, but it's fixed to the spine. And as we rotate the rod, we're correcting the deformity of the spine, like that. And once the deformity is corrected, we lock in our bottom screws so the rod can't rotate back into the deformity, and we change our coronal deformity and correct it. Now it's important to notice that even though we do this maneuver, it is a rod derotation, not a vertebral body derotation. The vertebral body may still be rotated because it's not rigidly fixed to this rod. And I think that's an important concept. And vertebral body derotation is an emerging technique that I think really benefits patients and reduces the thoracic rib hump. It's been studied, and it's sort of been defined as something specifically different than rod derotation. However, it hasn't been proven to actually reduce the rib hump, and I think that research is coming out still. This is the technique. We do the rod derotation, and the rod is locked in here at the bottom, but then the vertebral bodies in the middle that are still rotated are connected by long towers. Those long towers are then manipulated and derotated back into place, and in turn, that thoracic rib hump that often bothers patients is able to be corrected. And then after the vertebral body derotation is done, then the rod is locked into the vertebral body. And here we can see how the technique is done intraoperatively. And this is the technique of deformity correction. Another emerging technique, and I don't mean to overly nerd you guys out on the techniques of spinal deformity, but it helps you understand that there's a lot of emerging things that go into spine fusion, and it's not quite the same as it was 15 or 20 years ago. And some of these emerging technologies really help create an improved coronal and sagittal contour. If you look here, there's two different rod contours, and one of the surgeons that pioneered this technique found that if we put a rod into the spine that's very rigid and over-kyphosed, which means it's given more of a contour than we actually need in the final spine, that as we reduce the spine to the rod bends down gently, and the spine slowly starts to move up towards the rod. It's a different type of technique, but it's more controlled and more powerful. And the second rod is put in order to derotate the spine. And this technique works extremely well and is sort of replacing the traditional rod rotation technique, although both can be used in order to correct a scoliosis. And I will skip this a little bit, but this goes over the actual technical part of how differential rod contouring is done. And I touched on this, that to date, this vertebral body derotation hasn't been shown to actually decrease the rib hump. And I think part of the reason is because there's a lot of variability in how big a rib hump is and how well we're able to measure a rib hump. But anecdotally and in my experience, I think direct vertebral body derotation creates a much better cosmetic result. So I want to take you guys through a case example here. This is a patient with an adolescent scoliosis. We see a couple of different curves here. We see a 42-degree curve here. We see a 49-degree curve in the middle, and then we see a 35-degree curve here. How do you figure out which curve is the major curve? Well, we know that it's the largest curve. And how do you figure out which levels you need to fuse? We figure that out often based on bending films. If we ask the patient to bend to one side versus the other, we'll see that often these curves that are next to the major curve are flexible. And if they bend out to an angle of less than 20 degrees, that often tells us that's not a real curve. That's only a compensatory curve. And the same thing can be applied up here. When we have the patient bend this direction to the right, we also get a sense of how flexible the major thoracic curve is. If this major thoracic curve completely bends out and is very small, then that tells us that we would be able to correct the curve without a large amount of maneuvers, and maybe without having to do any significant bony cuts. Here we are, we look at our bending films. We see that this lumbar curve on the middle x-ray bends out to 15 degrees. That tells us that this curve is not structural, and we don't need to necessarily fuse that region of the spine. If we look at the side view here, we see that there's a neutral sagittal contour here on the lateral view, and then we generally try to stop at a level that's neutral on the side view. So here we have our breakdown of how we've analyzed this curve. The left bender flexibility is more than 25 degrees. So this proximal thoracic curve, this 42-degree curve, is still more than 25 degrees on the bending film, so it has to be included in the construct. But this bottom curve is very flexible, so it doesn't have to be included. So this classifies as a Lenke 2CN curve, which I won't go into the letters and what those mean. That tells us a little bit about the sagittal contour of the spine. And so we decide that we can do a selective thoracic fusion from T2 to T12. This bottom level is most often decided based off of the coronal film as well as the sagittal film, which level looks lateral. And often the decision is made intraoperatively. We look to see where we can neutralize that bottom level and have it be perfectly horizontal and level with the pelvis. So that's what's done here. We check the lower instrumented level, and we confirm that it's neutral and horizontal and level with the pelvis. We also look at the disc space to make sure it's parallel. If we can't get the disc space parallel, we use some intraoperative techniques, compression and distraction, derotation. But if we still can't achieve a neutral level, then we'll often extend the fusion one level. And then the other thing we check is we look at the clavicles to make sure that they're level, so that we have done our best to neutralize shoulder balance. And this is our final result. We see we take that scoliosis and we've corrected the deformity on the right in the coronal plane or the front view, but most importantly we've corrected the deformity in the sagittal plane too, or the side view. Our main goal in the sagittal plane is to not flatten out their thoracic spine, but really create a normal thoracic kyphosis. This seems to correlate with improved lung volumes and lung function, and it, I think, correlates with improved back pain throughout life, and I think a lower revision rate. So this is another area where there's a lot of innovation in how we're doing the surgery and a lot of efforts to make the surgery better. I want to transition a little bit now to adult deformity, and I think the reason I'm an adult deformity surgeon is I think there's a lot of overlap between adolescent scoliosis and adult deformity, and I think the training in adult deformity really applies to pediatric scoliosis, and I think specifically some of the techniques you use in adult deformity, as well as some of the principles that come from research are applied. And a lot of the surgeons that have innovated in pediatric scoliosis have been adult deformity surgeons. So I've been very influenced by both groups. I actually was pretty conflicted as a resident and applied to both pediatric and adult deformity fellowships for this reason. In adult deformity, the prevalence can be very high. It's up to 60%, but not everybody needs surgery for adult deformity. The way we figure out who's a good candidate for surgery is we look for who has pain that's intolerable in their low back and a radiographic deformity, and who actually has pain to the point that they're disabled and they're unable to walk and they're unable to do even the basic things they need to do in their life. And this is primarily what drives our decision making for adult deformity. Our complication profile for this type of surgery is much higher. In adolescent scoliosis, it's rare to get a complication. In adult deformity, it's almost a guarantee. The complication rate is often reported to be in the 70%, and I've had some mentors tell patients, and I do the same, where I tell them the complication rate is close to 100%, which basically means there'll be some bump in the road along the way, whether that would be an extended hospital stay, an infection, or a urinary tract problem, or a postoperative ileus, or some problem. It tends to be very common. And what I've found is patients that are really disabled and a lot of pain, that complication profile is acceptable, and they're still interested in the surgical option. The classification is much more challenging. It's heterogeneous, variable presentation. The most important thing that we need to think about as clinicians is that pain and disability are the main drivers of treatment, and that the sagittal deformity, the actual inability to stand up straight, is the main driver of surgery. Unlike adolescence, where we're looking at coronal deformity, cosmesis, and curve progression, in the adults, our focus is more shifted. And we found in our research that correction of sagittal plane deformity correlates with health-related quality of life outcomes, and we're able to show that correction of the deformity actually helps people be less disabled. So in this part of the talk, I want to talk about some key radiographic parameters, a classification system that sort of evolved for this type of deformity, and then also talk about osteotomies. Osteotomies are how we cut the bone in order to straighten the spine. And this goes into a little bit more of what surgeons think about, but the more we have to cut the bone to straighten the spine, the higher our complication profile goes. And so we often do everything we can to reduce the amount of osteotomies we need, and there's a whole decision making and science that goes into figuring out who needs these osteotomies and who doesn't. So this is our main drivers of deformity. We look at our adult population, we look at our lumbar lordosis. Those are the numbers here in the middle, 45 or 20 or 83. And the amount of lumbar lordosis that's normal is pretty variable, and it depends on the way you're built. Some people are built with a very high arch into their pelvis, a high arched sacrum going into their pelvis, and those people need more of a curve in their lumbar spine to stand up straight. Some people don't need a lot of lordosis. All patients, whether they're spine patients or not, tend to lose some of that normal sway in their back as they get older, and that's a normal part of aging. At some point, they lose too much, or they've had other spine surgery that's caused a flat back deformity, and they now are not able to stand up straight, and that becomes a main driver of pain and disability. So identifying this sagittal deformity is really important. We also look at this angle, the way the sacrum meets the pelvis is called the pelvic incidence. The pelvic incidence should roughly equal the lumbar lordosis for a patient to stand up straight. Some people have a pelvic incidence in the 80s, some people have a pelvic incidence in the 30s. And so for almost every adult spine patient, we measure their pelvic incidence, and we look and see what their mismatch is, the difference between their lordosis and their pelvic incidence. Another parameter that's really important is the pelvic tilt. This is basically telling us how much a person has to extend their hips or bend their knees in order to stand up straight. Often patients will do many different things to stand up straight, and that's often represented in their pelvic tilt. And here we see that if a person's pelvic tilt is more than 20 degrees, they're compensating for their deformity. That often tells us radiographically that there's a deformity and they're compensating, but we often make our decisions talking to patients, and we simply just ask them the question, can you stand up straight? Does it get hard? Is it hard for you to stand up straight over time? Does your low back hurt because you can't stand up straight? And that's often how we start our conversation, and we figure out what's the main driver of pain and deformity. The curves can be classified much in the same way adolescent curves are classified. We look at their coronal, their front view, as well as their side view. And we look at their pelvic incidence, their lordosis, the pelvic tilt, and another parameter which I haven't talked about, which is the sagittal vertical axis. That is basically a measure of how far forward their head is as compared to their pelvis. Basically, how much they can't stand up straight. And some patients will be able to stand up straight, but they have a real deformity that they're compensating for. And some patients just can't stand up straight, that they can't compensate for their deformity as well. We call that an uncompensated spinal deformity. And both of these patients can have a pretty high incidence of disability and pain. And in both of those situations, identifying the main deformity and correcting it can really improve their quality of life. Here's another curve, double curve here. This is probably a patient that had adolescent scoliosis that was untreated. And probably it started as a thoracic curve that then progressed over the course of the patient's life, and then they developed this lumbar curve. Now in adulthood, this is exponentially harder to take care of than in adolescence, which is one of the reasons I'm such a believer in treating adolescent scoliosis. Also, once a patient has kind of reached this point, Our goals for surgery are not so much to correct this to a perfect straight line, but rather to fuse the spine and help address all the pain that comes from the arthritis at these levels, and also to achieve a neutral sagittal and coronal balance. Basically make sure the patient can stand up straight and has an amount of back pain that they can live with. And here you see in this patient there is a pelvic incidence of 59. That's this measurement here. A lordosis of 44. So their mismatch is only about 15 degrees, which isn't a great mismatch. It isn't a significant mismatch. But they have a pelvic tilt of 24, which means there is some compensation. They're trying by changing the orientation of their pelvis to stand up straight because of their spine deformity. And then there is a significant coronal deformity, which unlike the adolescent population, is not the main driver of our surgery decision making. If the patient says they can live with it and they don't have a lot of pain, then we don't do the surgery. So the key parameters: sagittal vertical axis, which is the same as how much a patient can stand up straight, is a global measurement of imbalance. If somebody has a high sagittal vertical axis, that means they have an uncompensated spinal deformity. PI minus LL, that's your pelvic incidence minus your lumbar lordosis, and that's the amount of imbalance that's present between the pelvic incidence, the way your sacrum meets your pelvis, and the amount of curvature in your low back, and how much imbalance is there. And depending on how big this mismatch is, it sort of drives our surgical decision making. If a person has a large mismatch, we often need to do more bony cuts and more aggressive things in surgery in order to get them balanced, and then that does tend to increase their complication profile, and it sort of drives the conversation in the office one way or the other. For all of these patients, because this surgery can have a higher risk of complications, and also because the surgery is a major endeavor for a patient, we'll often never sign these patients up for surgery on the first visit. We'll just introduce it to the patients. We'll often look for ways that we can optimize them surgically, and then send them home, give them some time to think about it. And often I have them come back with families to really make sure that their disability is driven by their deformity. And the last measurement we really look at is their pelvic tilt, which is the amount of compensation with pelvic retroversion, which basically means how much you're extending your hips to stand up straight. And generally our goal is to get the pelvic tilt to within 20 degrees, and that correlates pretty well with reduced disability. This is the classification for adult spinal deformity. It can get a little hairy, to be honest, and it's mainly used for research at this point, and we don't necessarily classify every single curve in this way every time we see patients in the office, but it does remind us what the main drivers of disability are, and it tells us that for every patient we have to be looking at their pelvic incidence and their lumbar lordosis, we have to look at their sagittal vertical axis, and we have to look at their pelvic tilt. These are the main drivers of our surgical decision making, and it also helps us identify which patients may be more likely to have a radiographic deformity that's driving their disability. And then we also look at their coronal curve, and this is often done to make sure we can get them within an appropriate balance. So what? Does the classification system predict outcomes? Does it predict surgery versus no surgery? Does it help plan surgery? Why do we classify all these curves? And the truth is, it does predict outcomes. We know that if we look at their sagittal parameters, when you correct their deformity, it tends to correlate pretty well with their improvement in disability. So a patient that has a deformity and is very disabled, and we measure their ODIs or their outcomes that correlate with their disability. If we correct their deformity, it correlates with improvement with their disability score. So people become less disabled if we correct their deformity, specifically their sagittal deformity. We also have an emerging system for cervical spinal deformity. This can get a little bit complicated as well, where we look at their chin-brow angle and their cervical sagittal vertical axis, as well as their C2 to C7 translation. And we also look at cervical lordosis, and another parameter we look at is T1 tilt. And I don't want to go into too much detail with this, but there's a whole science that really drives our decision making in these patients, and how we decide to do surgery and how we pick levels. And often we can figure out who has a cervical spinal deformity by asking the simple question: can you raise your head up? Does your neck hurt when you try to look straight? Does your neck get tired at the end of the day? And if somebody sort of answers yes to a lot of those questions and they're a reliable patient, then we start to look at these different parameters, often identifying the correct patients and screening the patients to know which patients have a real deformity that's driving their pain is a large part of what we do. I won't even get into this, but the classification for cervical spinal deformity is extremely complicated, and it's still in its development stage, to be honest. It doesn't necessarily correlate extremely well with outcomes, but it's used as a way to pick fusion levels, decide on who might be a good candidate for surgery, and it's used for research. And these are the different type of deformities we can see in adult spine. And this is where I think there's a lot of overlap between adult spine and pediatric spine, is if you understand the complexity of adult spine and you get comfortable managing adult spine, it can really help you manage pediatric spine. And it can help with the decision making in deciding which patients would need surgery, which patients don't, and which levels to fuse. And the other advantage is you're able to follow your patients into adulthood. So these are some of the different cervical deformities. Primary cervical, where there's a curvature right in the cervical spine. Here's one right at the cervical thoracic junction, right in this region, a little bit difficult to see. This is a deformity that's really being driven by the upper thoracic spine, and there's just not enough strength in the cervical spine to hold the head up straight. Just doing a fusion in the cervical spine would not correct this and would probably lead to a failure. And there's also coronal deformity, which tends to be more rare. And in rare situations, more in rheumatoid patients, will have the occiput actually fall into the cervical spine. You'll get basilar invagination. There's also an osteotomy classification where we basically look at how much bone we have to take out in order to correct somebody's spine. And I'll go through this quickly, but you can do type 1 osteotomies where we're just taking off a little portion of the joint. Type 2 osteotomies where you're taking off both sides of the joint in order to create a sway in their back. Here you can see the patient had a relatively flat back, and just through small little bone cuts we're able to recreate a pretty normal sagittal profile. Grade 3 is where we take out the entire pedicle. This is a wedge-shaped cut that's used to give a curvature in the back. Now this surgery comes with a little bit of a higher complication profile. These nerve roots that are next to the pedicle have a higher risk of being injured. Our blood loss for this type of surgery typically goes into the 2, 3, 4 liter range, if not higher. Both the anesthesia team that worked with us that day has to understand why we're doing what we're doing and what the blood loss is for, and also the patient has to understand that we're doing surgery for a specific reason, and that this wedge shape is the only way to create a normal sway in the back. And this is typically done when there's no other option, typically through a prior fusion, where another fusion was done, the patient was still fairly mismatched and still disabled. So this is done more rarely and only done in situations where you can't correct the spine, otherwise it's already fused. An extended grade 4 osteotomy is where you do a similar type of wedge, but you go into the disc space, has a little bit more power. Vertebral column resection, this is done sometimes for tumor. We'll do this type of procedure. We'll do it sometimes for TB. I do some missionary work in Africa, and some of those patients will have multi-level POTS disease, and we'll have to do a 2, 3, or 4 level vertebral column resection just to correct their deformity. So this is typically done a little bit less in the lumbar spine as shown here. More often we do it in the thoracic spine. And the indications are sometimes deformity, sometimes tumor. And the goal here is to get more aggressive correction. Grade 6 is a multi-level vertebral column resection. Again, we do that for very severe deformities like this in the thoracic spine. We'll do it for patients that maybe have a tumor infection or curves that exceed 100 degrees. Then we're really not able to get it with small bone cuts. Some of the new things that are on the horizon, which are really in the last 5 or 7 years, are looking at global sagittal balance and different ways that people will compensate by bending their knees, extending their hips, even things that people do in their cervical spine to compensate for a problem in their lumbar spine. This is an exciting area of research, and it will probably drive a lot of our decision making in the future, but it is not hard science yet. One of the things I trained at UCSF, and one of the things I trained under is a two-surgeon model for spinal deformity. And the reason we do this is there's a good amount of research that blood loss is decreased when we have two surgeons, and our OR time is decreased when we have two surgeons. A single surgeon model would typically at UCSF, blood loss was typically in the 3 to 7 liter range for surgeries where we were taking out the pedicle. And with a two-surgeon model, we're able to improve our efficiency, move quickly, which often reduces OR time and blood loss, and anecdotally reduces surgeon stress. This is the model that we've sort of employed here, and I do this with patients. Anybody that needs a complex spine surgery, we do with a two-surgeon model. I use a neurosurgeon that is here that is trained with me as well, and we typically do these surgeries together. It really is beneficial for the patient. The other advantage is that patients get two different opportunities to talk to their surgeons about the surgery. They talk to me and they talk to the other neurosurgeon, and they get two perspectives, and the families get two chances to ask all their questions and decide if this is the right thing for them. I do feel this is probably moving towards being more standard of care for spinal deformity. So I have a couple of adult spinal deformity cases I wanted to show, and then we'll wrap things up. This is a 65-year-old male that showed up in the office with a complex spinal deformity. He had unable to walk more than 100 feet, severe back pain, and he finds his condition to be intolerable. Patients really have to say that they are disabled and their back pain is intolerable and they just can't live with it. And often we'll send them to non-operative people or counselors to make sure that there's really their main driver of disability is in fact their deformity. When we look on his films, he's got a coronal deformity on the left side. You see it's shifted off to the left about 9 centimeters. He's also got a sagittal plane deformity where he is got a lordosis, but he's got about 40 degrees of kyphosis across the thoracolumbar region. His pelvic tilt, which is a measure of how much he's compensating, is 35. This tells us that he's compensating for this deformity. He doesn't have a very high sagittal vertical axis, which means when you look at him, he still stands up straight. His pelvic incidence is 55, and his lordosis is 38, which isn't a very big mismatch, which tells us that the main driver of this patient's pelvic tilt and deformity is this region of kyphosis here. So we planned a surgery where we did a two-surgeon approach and a one-stage surgery to correct both his coronal and his sagittal plane deformity. We first addressed his cervical myelopathy, which is addressed with a cervical surgery, and then we discussed this at a multidisciplinary conference, planned out surgery, got two surgeons involved, planned on 1 versus 2 stages, osteotomies, which were smaller bone cuts, and we planned for a possible pedicle subtraction osteotomy to correct the deformity at the thoracolumbar junction. So often we'll go into these surgeries with a plan A, a plan B, a plan C, a plan D, and kind of that decision making intraoperatively is sometimes what is better when you have two attending surgeons working on these cases. And this was our final result. Surgery time was about 10 hours, blood loss was 1,400 cc's, which was good. We achieved excellent correction of the coronal deformity and excellent correction of the sagittal plane deformity. We reduced that deformity in the thoracolumbar region, and we reduced his pelvic tilt to within 20 degrees. Post-operatively, the patient had a heart attack and needed to be placed on anticoagulation. Thankfully, the patient recovered without incident. He was also then readmitted a month later with a wound infection, and that needed to be cleaned out. But now the patient is 3 or 4 months post-op from surgery and is extremely happy and less disabled. So this underscores some of the controversies with this surgery is that the patients are often very happy. Our outcomes can be very good, but there's very often a bump in the road, which is why we study these patients clinically. We do research on their outcomes, and we often employ a two-surgeon model to do everything we can to reduce the complication profile for these patients. I often will tell patients that it's best to think about this for at least a month or two before undergoing or making the decision to have surgery. But this experience helps us, I think, care for patients and improve their quality of life. This is another patient, 2 prior spine surgeries, progressive difficulty standing up, significant disability, walking tolerance is less than 100 feet. He's been treated by pain management, no improvement, pain pump that didn't help, and he really felt his current condition was intolerable. When we saw him in the office, he had a significant obesity. He was pretty heavy, so we asked him to lose some weight to reduce his infection risk, and we delayed surgery 3 months. We did a DEXA scan to check that he didn't have osteoporosis. We did some preconditioning with physical therapy. We did a CT myelogram. We had a family discussion. We discussed at our multidisciplinary conference. And then we planned out our surgery. This was his deformity preoperatively. You see the patient's head is over here and the pelvis is over here. That's not really very compatible with a high quality of life. Pelvic incidence was 70 and the lordosis is 28. When the mismatch is that high in the 40-degree range, it's very significant and it's very hard to live a high quality of life. His sagittal vertical axis was 20 centimeters, which corresponds pretty heavily with a significant disability. And his pelvic tilt was 42, which tells us the patient was compensating the best he could to stand up straight and still wasn't able to. So our plan was to do a T8 to the pelvis with an L4 pedicle subtraction osteotomy, remove the old hardware, and we aimed for an age-adjusted correction, which means we don't overcorrect, with about 30 or 40 degrees of lordosis, which is that normal sway in his back, and our goal is to get him to stand up straight. And this was our outcome. The surgery was an all-day long surgery, 10 to 12 hours. Blood loss actually in this case was pretty high. And you see our final outcome, the patient's able to stand up straight. And in this region is where we do our pedicle subtraction osteotomy. Post-operatively, the patient was in rehab for about a month, but is overall doing well. Now he's about 3 months post-op from surgery. We're able to get his lumbar lordosis and his pelvic incidence within 20 degrees. His pelvic tilt, we didn't quite get to within 20, we got it to about 25 degrees. And our correction through our osteotomy was about 30 degrees. We didn't quite get 40 degrees, but we got 30. And then sometimes that is the reality of doing these surgeries. We don't get, as always, as much correction as we predict. Sometimes it has to do with the quality of the bone and the osteophytes in the region. But overall, the patient is much improved. And luckily, this patient didn't have any major complications during his hospital stay. So it was an excellent outcome. All right, well, I hope you guys enjoyed that talk. Thank you for your attention. Please feel free to reach out to me if you have any questions. You can email me at vermak01@uw.edu. That's VERMAK01@uw.edu. Thank you so much.